Okay, so I'm Veronica Miles, and today I'm going to be talking about debriefing in the ER. So the reason I wanted to talk about this specifically is I think that it's something that we underutilize, and it can be beneficial to ourselves and to staff and patient care, as well as improving processes in the ER. So this is, kind of what we think of when we all think of debriefing. So we're going to kind of talk about the who's, the what's, the why's, the where. So what is a debrief? So it's a facilitated or guided reflection in the cycle of experiential learning. And it focuses on individual teams, processes, or system issues that, if you make modifications to, could potentially benefit the patient with a similar presentation. So the purpose is to kind of facilitate discussions about actions and thought processes that occurred during the event, encourage reflection amongst the staff and those involved, and to ultimately assimilate those behaviors, improved behaviors that you decide on into clinical practice. So different content that you can look at, things such as clinical management, was the management appropriate? The technical skills, was there any issues with procedures or, for example, compressions that were performed? You can also look at teamwork that was involved in the case, and then any behavioral issues that they feel occurred. So this is done a lot actually in simulation-based education. There's commonly a debriefing after the case to talk about these similar things, like what was done well, what wasn't done well. And, in the ER, usually after deaths or cases that are emotional or highly charged, it can be a way to facilitate open feedback or an unexpected negative outcome, a case that went wrong, kind of why they think it happened, and to discuss feelings or events with the staff. So one thing that can be done is standardization, meaning that there's certain clinical events or things that trigger a debrief automatically, and that can kind of increase the frequency of these happening. So for an example, if you did septic shock, you can talk about, did we follow the metrics? Did we get the time to fluids, time to antibiotics? And then you can, like I said, select different triggers that will kind of incorporate it into the culture of the ER and allow these to happen more frequently. So why do we do this? Kind of talked about this a little bit. It can improve effectiveness of the team. You can identify what we're doing well and maybe not so well, and barriers and improved outcome. So I think if, it can be a powerful tool that can change team behavior. I think if you're talking about how it went well or having that open communication and discussion, I think you can work better as a team. And then really the focus is on future team performance. So not really blaming an individual, but taking a look at the facts and different perspectives that could improve processes for future outcomes. And then understanding also kind of what attributed to an error. Can you find something that potentially went wrong, and was it a result of something that you could correct in the future and benefit the future patient? And then barriers, is there something that's consistently happening, like a protocol, trauma protocol, or scheduling, or where something is in even in the recess phase, something that going forward, if you correct that, could affect future cases. And then ultimately, there was a meta-analysis I looked at that with team-based debriefings, there was improved effectiveness in teams compared to those who did not. So with CPR, right, I think that's kind of the standard one people may consider debriefing after, but it actually shows that debriefing programs had a higher rate of return of spontaneous circulation in teams who did regular debriefing. So it had higher ROSC, better neurological outcomes, less delay in time to first compression and less time off the chest. So, you know, there's a lot of the things I feel like we do in CPR, there's not great evidence in terms of, you know, neurological outcome or, you know, like the meds and stuff that we give. But if we could do a debrief and potentially impact outcomes, I think that could be very beneficial. And actually, American Heart Association, the guidelines do officially recommend using debriefing after resuscitation to improve clinical performance. Okay, so who's involved in a debrief? Really like all active team members who participated in the case, and then a facilitator as well. So this can be, you know, the physician leader, the nurse, respiratory therapist, any secondary nurses that were involved, med students, residents, pharmacists, social workers, patient advocates, anybody that was really there should be included. And you should encourage participation. Obviously, if someone is, you know, really emotionally charged or unable to attend, then you would not want to push them to do this. And you can consider involving like patients or parents, but that may, as you can imagine, kind of affect how the conversation goes or the scope of and content of kind of like what you discuss in the debrief. So, and it also may consider like medical legal. So I think really focusing on the team members is where we'd get the most benefit from this. And then, you know, you should have an authority figure, whether that's the charge nurse, the lead nurse, the physician that led the case, just someone that can kind of facilitate this and kind of make sure that you're doing this in a non-judgmental way and kind of facilitating open communication. Sometimes, you know, like the documenter may be a good choice, like the nurse who's doing the documentation during the code, because they'll have timing of when meds were administered. They'll have, you know, documentation of all the critical actions that occurred. So they may be able to kind of give you a little more clear timeline, which I think, you know, most of the time when I've done debriefings, I've always led them. So it's kind of different thought of having other people be a facilitator. Okay, and then you know, there's also another survey where they actually had like a trained debriefer that were involved in these, and kind of what they came out of that is that you can use like a script, you know, have like an evidence-based script on hand, just to standardize your debriefings. So kind of talk about now, how do we do this? You want to make sure it's a friendly atmosphere, that you're using open-ended questions, honest dialogue. You want to have objective data, and you can also do like a root cause analysis. So, you know, like objective data, like I talked about the code sheets, you can even like if you have video recording of the event, like especially like I talked about a sim case. And then if it's a high risk case, like there was a preventable death or unexpected, then you may even do a more formal detailed root cause analysis, you know, like an M&M, like we do on certain cases. And then the most common kind of method for debriefing is called this plus delta. And so that's just kind of like what went well, what did not go well, and what can you change. So kind of like we already talked about. And then the emphasis is not on the error, but kind of why it happened and how can we prevent it in the future. And you want to do directed feedback and description, analysis, and application to future events. And that's where we kind of talk about that. There's debriefing tools or debriefing scripts that you can use to kind of go through these. And then in terms of the STOP, this is kind of like short acronym, you know, so you summarize the case, things that went well, opportunities to improve, and points to action or plans going forward for the next patient. So if you're, you know, can't remember, you don't have that descriptor in front of you, that's just like a short little way to think about it. And I think if you hit those points, you know, you get some benefit. And then when do we do it? So when we talk about debriefing, there's hot, warm, and cold. So most of the ones we're going to do are hot ones. It's immediately after the event. That really should be the way it should be done if feasible. And like with hot and warm, you're going to have the people that were involved. It's going to be fresh in your mind. And, things that can and if there's any emergent issues or things that you find that they can be addressed quickly. Sometimes that can't be really done. You may have limited staff or limited time or other clinical obligations that would limit it. So you can do cold debriefing. Kind of the benefit of that is you can have people that weren't involved in the part, like in the case, that they can be present. You can do, like we talked about, more of a root cause analysis. And you can have like a larger group in a different space, because most of the time, you're in the ER, there's limited space as well. So that kind of leads into the next thing. So most of the time these are going to occur where the event happened. So usually in the ER. And then, like I said, if you're doing a cold one or you have a larger team, you can try to find another place to have this discussion. So what's next? So we talked about, the 5 W's, but what happens next? I think, when you do these debriefing, scheduling and designating a follow-up person for issues that you find is important, because we can sit and we can talk about it, but really having someone that's going to do that follow through, and let's say we find a critical system issue, fixing that and addressing it so that the next patient gets benefit. And then dissemination of information. So finding a way, if there's a learning point or a learning action, and finding a way to kind of disseminate to the staff too, like to the nurses and other people in the ER. So like if we find something like hanging a poster or doing a monthly email, just to kind of send it out and disseminate it. And then resources, a lot of these cases, when we do them, like you talked about, they're emotionally charged, or maybe a death, or maybe a pediatric patient. It may hit certain staff members harder than others. So ensuring that you let them know there's resources available to them. And, sometimes, like, you think of yourself as a second victim, right? Like, you are impacted also by these cases. So I think that not only does it find a system error that could be addressed, but it also addresses the emotional well-being of your staff and even yourself. So are we doing it? Short answer, probably not really, not as much as we should. So there's a few studies or surveys that I looked at, and I mean, it was like less than 25% of resuscitations had a debrief. A lot of people said that they recognize the importance of it, but they didn't really have, enough time, any like a trained facilitator, or really like an appropriate setting to do these in. So one thing, that could help make this more often is finding somebody that kind of begins a program or sustains it, finding those cases that we say, when this happens, we're going to debrief, and encouraging like your peers and partners to do more debriefing as well. So I think it just goes along with a culture of safety, for patients and for staff, and identifying things that we can do to help patients in the future. So that's pretty much what I have. And then there was one more case study that I was reading, where they did like 40% of cardiac arrest cases had like a hot debriefing right after. And the changes that occurred, they moved around some of the recess equipment. They made different changes based on these debriefings, and like 95% of people that participated felt that it helped with their practice and that they benefited psychologically from it. So I think it's just something to consider, maybe incorporating more often. That's it.